Hello, hello. My name is Haley Waddell, and I'm going to be giving a lecture today. So let me just share my screen. 1 second. Okay, so go back to the beginning. Okay, so I'm going to be giving a lecture today on the topic of the patient-provider relationship, the relationship that you have with all of your patients. We're going to be going over all the aspects of it, why it's important, and then the unique and key elements of it. And we're really going to be diving into how to have these good relationships with your patients and the impact it can have for both you and your patient. So, let's get started. So, on today's agenda, we're going to start by defining the patient provider relationship and its key elements. Let me start my timer. All right. Then we're going to define and give real life examples of the four models or four types of the different physician patient relationships. Then we're going to address how much personal information you as providers should share about yourselves to your patients. And then we're going to navigate unique or difficult types of relationship that you have with your patients or situations that might arise that might be unique or different or something that you might not encounter every day, but there's a real chance that you might encounter someday. Okay. Next, we're going to go over the conflict management and resolution with your patients. I mean, it happens, so it's very important to be prepared for that. And we're also going to talk about how to terminate the patient provider relationship with your patient if needed, if it comes to that. It's a very tricky situation, so it's important again to be prepared. Then we're going to finish up with some systemic barriers and solutions, and then the conclusion. So, lots of stuff on the agenda today. So, let's get started. Okay, so introduction. So, what exactly is the patient provider relationship or dynamic? I mean, stated in its most simple terms, a patient physician relationship exists when a physician serves a patient's medical needs. I mean, that's the most basic. If patient comes in and you're there to help whatever they need medically, and that's the relationship. But it's so much more than that. There's so many moving pieces. So that's just it stated in its most simple terms. And generally, the relationship is entered into by mutual consent between both the provider and the patient or surrogate. So, why is this relationship important? So, patients sometimes reveal secrets, worries, and fears to physicians that they may have not yet told to friends or family members. So, placing that trust in a doctor or provider helps them maintain or regain their health and well being. It's very important. There's two sides to this relationship that are both equally have their roles and importance and for both of your well-being, both you as a provider and your patient. So this relationship is one of the most sacred relationships that you could probably be in because of how vulnerable as a patient they are and coming to you with, you're going to see them in their worst times possibly. So it's very important to, try to increase the efficiency of your relationship. Okay. So there's four key elements that the four basis that makes and creates this relationship, a good relationship that you have with your patients and the patients have with you. So this unique relationship encompasses four key elements, which are the foundation of the patient-provider relationship, which is mutual knowledge, trust, loyalty, and regard. So we're going to go over what each of those mean. Okay, so starting off with mutual knowledge. So, knowledge refers to the doctor's knowledge of the patient as well as the patient's knowledge of the doctor. So, how well do you guys know each other? Next, trust. So, trust involves the patient's faith in the doctor's competence and caring, as well as the doctor's trust in the patient and his her beliefs and report of symptoms. Does the patient, trust that you know what you're doing? And do you, as a doctor or provider, trust that the patient is telling the truth about what's going on and or their medical history or what they're feeling? And so this is important. Trust is like probably the most important part of this relationship. Next, we have loyalty. So, loyalty refers to the patient's willingness to forgive a doctor for any inconvenience or mistake, and the doctor's commitment to not abandon the patient. So, with regarding to loyalty, does does the patient are they willing to forgive you and like stay with you as a patient regardless of like any mess ups you might have or time constraints or wait times or you not being available for appointments? Are they willing to work past that to be your patient still, no matter the hardships, no matter the waiting time, because you're worth it? And then you're on you the provider's side. Loyalty refers to, your commitment not to abandon a patient, not to abandon them when they need you, not when they want to book an appointment, when they want to see you. Are you there for them when they need you? Okay. So, and then finally, we have regard. So, regard implies that the patients feel as though the doctor likes them as individuals or is on their side. Um, So, does the patient feel like you have their best interest at heart? Do they feel like you want them to get better? Do they feel like you want to hear about what's going on with them? Do they, do they want to know that you care about them as an individual and not just an object or something else that you have to do that day? So, we're going to go over the four key elements on the patient provider relationship at work in different patient scenarios. Okay. So, so this is I kind of constructed it in a way. So this is really patient scenarios and how it affects the relationship, and then we'll go on provider type of factors that play into. So these are just situations that you might have with patients that can impact the relationship. So this patient situation we have is the new patient, the one that you've never seen before. They just book an appointment with you where you just got assigned to them and you've never seen anything before. You don't know anything about them, right? So some strains that this can have on your relationship with them is that trust has not been established. You don't trust them, they don't trust you because you don't know them. And that goes with knowledge. The doctor does not know the patient and vice versa. It's a brand new patient. You're brand new to them. They're brand new to you. And then loyalty, there has not been opportunity to demonstrate that loyalty yet. So, it's important that um, you make the most out of this first impression and take 7 seconds to make a first impression. So, especially with this new patient, are they gonna be your long-term patient? Are they going to have that loyalty to you? Are they going to trust you? It's all to you. I mean, it is up to them as well because it's a two two part of this relationship. So some solutions to maximize this relationship or get or establish a relationship with them is maximize the patient's comfort of feeling of being liked or uh, you know, cared for, heard. Like, that 7 seconds is important for you to come in and make it seem like, you want to know them, you want to know where they came from, you want to help them and, make them feel comfortable, you know, establish that rapport with them. Like, hey, how are you? What's your name? Where are you from? Like get to know them as a person and not just a patient. So, yeah, that goes on with knowledge. Take time to get to know the patient to maximize your knowledge of the patient because the more that you know about them, the more you know their history, the better that you can take care of them and better you are prepared for their treatment or whatever they might need. And as well as on their side, they feel that you care. They feel that, they're being listened to, they're being heard. Um, and, it's their also opportunity to get to know you and what kind of doctor or provider you are. So it's very important. And you'll always have a new patient no matter what. Like, so, It's important to establish that relationship early. Okay, next. Okay, so the next patient factor that we have is, giving them a poor prognosis, or, them having a poor prognosis. It's hard for both parties. Um, so, some strains that this can cause on your relationship with them is medical knowledge and interventions may be exhausted. Like you've done everything you can. You've gotten that second opinion. You've gotten some tried to get some help to give them a better prognosis, but there's nothing more you can do. Um, and that's hard. It will take a strain on your relationship with them because, they came to you to get better and there's nothing more you can do. And it's very frustrating for both parties. And then in terms of regard, a physician may damage his or her relationship with a patient if the physician fails to recognize when treatments is futile but continues to aggressively treat the patient anyways, rather than focus on the patient's goal of care. So as a provider, we have one mission is do whatever we can to help them. Do whatever you can, do whatever in your means and that you have the resources to help them and to help their condition and like heal them basically. So this poor prognosis, some providers have a hard time accepting that and they will just keep pushing, be like, and go to experimental things or things that they might not be have experience in, just to try it. But sometimes there comes a point where like enough is enough, especially, and you have to remember that they are people and that everything that you're doing is affecting their well-being mentally and physically. So it can be exhausting and draining for the patient. And as a provider, it's hard because you have to know when to keep going and fight, and then you also have to know when enough is enough. And it can be a hard pill to swallow, I understand, but if you want to that relationship with them, like they're it's going to be hard because you have to treat them like I know you care, but they're people too, and it's enough is enough, right? So that can be strains on the relationship for a patient who has a poor prognosis. But some solutions to this is, ensure that the patient knows that you've done everything possible. They might be in a state of denial or they might be angry at you, but it's important for them to know that you've done everything you can because then that relationship can still be there. And if it's been there already, then they trust you that you care, you've done everything you can. You can go over all of it again if you want to, but there's nothing more you can do, and that's hard. That must be hard. That's for them, to accept and for you to accept. So loyalty, do not abandon the patient. This is the time that they need you the most. This is the time that, their world is crashing down on them, with facing the end of their life possibly. And, they need more support now than ever. And so it's really important for you to stay loyal to this relationship with them and, don't abandon them. Don't abandon their autonomy. Don't clock out, because everything that you've been doing that led up to this moment, you have to get to the finish line with them. That's your duty as their provider. And then regard, find out what is important to the patient and work with him or her to maximize the quality of his or her final days. You know, this is where hospice comes in. This is where, you get those outside, so bring social work in to get those outside resources to make them comfortable for their end days. But you want to be a part of that too. And because for your relationship, like you've known them longer than maybe the people that you're bringing in after this poor prognosis. So it's important for you to stay there and help find those outside resources for them for the sake of your relationship. All right, get back to it. Okay. So next situation we have is, the patient that has a frustrating disease or condition. Um, you know, So strains that it can cause on your relationship with them is, the doctor might not trust the patient. It might, you might not trust as a provider that they are doing what like adhering to their treatment regimen to get better, because you're just like, I'm telling, are you doing everything that I told you to do when you're at home? Like, are you doing, you might not trust that the patient is being truthful, when they leave this office or leave your office. So, and then another thing is the patient and the physician might not like each other. The patient may feel judged, and the doctor might have trouble being empathetic. In high stress situations or something that that you don't understand, it's confusing. It can be, stress can and emotions can run high, um, and you might, as a provider, lose that ability, the original ability to be empathetic because you're so frustrated and you're so caught up in what's not going right or what's going wrong. You might be so caught up in it that you might take it out on them, ultimately. And so some solutions for this could be, make sure that the patient knows that the physician is there for, continue out that important parts of the relationship, like continue to reassure them that, you're doing everything you can for them and that you're there for them. I know it's hard, but, you know, continue to be on their side, and have their best interest at heart. Another thing is educate oneself about the disease in question and the best ways to connect with the patient. Create a dedicated team to support the treatment team for a challenging patient. In the case of substance abuse, for example, studies have shown that the patient is in integrated care groups are more likely to remain abstinent compared to those in independent care groups. So, if they have a frustrating condition and nothing's getting better, it's it can be helpful for you as the provider to do that extra research, and get that extra help from other resources to try to help this unique situation or this unique type of patient. um, you know be creative, get enact your problem solving skills, research what's been done in the past with other people with this condition and what's worked for other people that you might not have tried before. Get creative to really keep that relationship with them and keep it moving forward and trying to help them. And it really helps with trying new things, shows them that you're not willing to give up on them. Next situation. All right. So, we've all had this, the difficult patient, the patient that you're like, ugh, you see their name, you're like, ugh, I don't want to deal with them today. I don't, she doesn't like me. I don't like her. She's gonna, I'm not, you, we all have those. We've all encountered those. So, some strains, I mean, they're patients too, though, and you have a relationship with them, whether it might not be good, whether it might be good, that's one thing, but you still, if you're their doctor, if you're their provider, if you're taking care of them, part of their healthcare team, you have a relationship with them. So, might as well make it the best out of it. So some strains that this can have on the relationship is the patient might dislike the physician, the doctor might dislike the patient. It happens. Because even though you're a provider and they're a patient, uh, at the end of it, at the end of the day, we're people, we're human. And we can't like everybody. Not everyone can like us. It's just you're not compatible with everybody, and that's fine. So maybe some solutions to make this relationship make the best out of it is the physician should actively evaluate, your own feelings towards the patient, self-reflect, which allows the physician or provider to use his or her own emotional reactions toward the patient as a diagnostic information, and allows the physician to thoughtfully change the interactive styles with the patient to reduce tension. So, you can't change other people, but you can change your reaction, uh, how you react to them. You can change yourself. You can change, um, how you address the situation. You can so this difficult patient or whatever. You can't change them. They're not going to change. There's nothing you can say, uh, to get them to be less difficult, I guess. But that's where it's your responsibility as the provider to self-reflect on your own emotions about how you feel about them and how maybe you can overcome those emotions or approach them in a different way to reduce that tension that has been there in the past. Um, so really that self-reflection and address your own emotions and reel them in. So because you can't match a difficult patient by being difficult. It's just not going to get you anywhere. So next, okay. So health literacy. So possibly a patient with low health literacy. Um, you know, you might they might come in and they might be a perfectly look normal, like, say 35-year-old. So you're gonna automatically assume that they, went through school, that they learned how know how to read, they graduated, high school, but it might not they might not be where the level that you think they are. So, some strains on the relationship, with a low health literacy type patient is the patient may not feel as though he or she has a basis on which to evaluate a doctor's competency. You know, you might be talking to them, you might be treating them, and they don't really have the knowledge or capability of understanding if what you're doing if you're doing it the right way, if you know what you're talking about. They don't really have the ability to judge that about you because they don't really have the background. So, and also knowledge, the doctor may provide educational materials that are above the patient's literacy level. So, you might provide a pamphlet or at-home instructions on how to take the medication that you prescribed, but it might be above their literacy level and they're not going to be able to understand it, which ultimately they're not going to be able to adhere to their treatment regimen and affects their health and their care plan. So, next thing is also a constraint on the relationship is the misinformation may increase the risk of communication failures between the patient and the physician. For example, using medical jargon may alienate a patient. So, if you're there using a bunch of medical terminology that they don't know, it's going straight over their head. Nothing, they're not absorbing what you are telling them. Um, and it might make them feel even more anxious, even more alone in their condition because they feel so out of place. They don't know what's going on. It can be really uncomfortable for them. So some solutions to this barrier. So physicians or providers should evaluate their patient's health literacy and tailor the discussion to the patient's level. The doctor should have the patient do the teach back method to ensure understanding. So, you know, this should be addressed early in the relationship of what's their capability of understanding you? Do they really understand what you're talking about? Do they really understand their condition? Do they have the capacity to go home and, you know, follow instructions, take care of themselves? So that should be addressed early on with just talking to them. And, one way that you can address their understanding without asking them, hey, do you understand this? Uh, a lot of patients will just say, yeah, even though they don't, and they'll go home, forget it, and it'll be frustrating more work for you, right? So the teach back method, once say you're giving instructions about a medication that's take once a day with food early in the morning, like once you wake up, you know, you can ask them. So when would you take this tomorrow, for example, and then they can tell you if they were listening or not. About when to take it. So then you can, if they repeat back to you what you just said, then you know that they have the ability to understand and follow directions. Okay. All right. The last one that we're going to go over for patient factors for the relationship is family pressure. Um, you know, people, different cultures, especially like to involve their family heavily, and especially this can happen with dealing with a pediatric demographic. Their family is most likely always going to be there, a part of it in some way, because they're minors. Or you're dealing with the adults and their spouses, um, and or just some people just have big family and that are always there and they're always in there when you're caring for them, always in the room. And so not only now do you not only have to talk to that patient, but you also have to now their family is your patient as well. So some strains that this can cause on your relationship with your patient, with that patient, is a family may question a doctor's provider's competence. The physician may not trust a family member to serve the patient's best interests. So, uh, you might be explaining, okay, we're going to do this for you, uh, whatever. And then a family member might chime in and be like, well, I read an article where they said that's not good anymore for him, whatever. And so they might question you and your, ability to make those right decisions for their family member. And it can be really, really hard, frustrating, because, you're trying to talk to your patient, not them. But unfortunately, like it happens. And you might have to over explain yourself. You might have to group their family in, with your patient. And then also, like, you might not trust that the family member has the best interest of your patient. You might question their motives when turning down, say, a surgery or a treatment that that would help them, but they want to turn it down for some reason. So you're like, you know, and it will interfere with your ability to be able to take care of that patient. And then, so another thing is a family may know a patient better than the doctor does. Of course, they might know the patient on a personal level better than you do, but you are the one with the educational and the medical training background. So, it's sometimes providers can find themselves competing um, with the family about what's best for that patient, and it impedes your ability again to have that connection with that patient, and because their family's always there, right, questioning everything you do. So some solutions to this is a doctor and other members of the care team, including nurses, social workers, techs, should keep family members appropriately informed of patient status and frequently have family meetings that can be arranged. So it's no use. You're not going to get anywhere trying to push away the family or compete with them, or, they're still going to be there. And no matter how much you do not like or care for the family to be there, it's still that patient, your patient's family, and they care about them. Um, so instead of being on a separate team than them, competing with them, or a separate, include them. Include them in what you're doing. Over communication is better than under communication. So, keep them informed, keep them a part of it, because their family member is, in this medical situation that they have no control over, and it's scary, and they might tend to lash out at you. And so it's important to not only keep that patient well informed and at ease, but also their family, because it'll make your job easier. So, have those frequent meetings with the family separately if needed, um, and keep them, let them have some control, let them be a part of the discussion, because it'll uh, it'll decrease that pushback from them. All right. So next, we're going to go over how the four key elements of the relationship, work in different provider scenarios. So we just finished the different patient type scenarios that could impact the relationship negatively, but now we're going to talk about some situations that the provider brings in to the relationship that may hinder or strain the relationship that they have with their patients. Okay. So the first one is physician burnout, provider burnout. It happens especially during COVID and the high patient to provider ratio. It it happens, and it's hard to still focus on the little things when you're just so exhausted mentally and physically. So some things that this how this can strain the relationship is lack of trust can lead lower levels of patient satisfaction and longer recovery times. The emotional and behavioral consequences of burnout, for example, ineffective communication, also jeopardizes trust and may damage the trust that the patient has in the physician competence, because they can see, if you're emotionally and physically exhausted, they can pick up on that, and it might impede their ability to be able to fully trust you that you are capable mentally to take care of them or to uh, do their treatments or make those decisions because they can tell you're exhausted. Another thing is it is harder for emotionally exhausted physicians to show affection or empathy. So when physicians are burned out, their patients are more likely to report that the physicians use non-empathetic statements, especially if it's like your last patient of the day, you're about to go home, you just got off a 12-hour shift and you have this last patient, you're just like to go in, tell them, do your job, and you just want to go home, right? I mean, that patient, it's not their fault, but and they can also pick up on that if you don't want to be there. So, it's important to still have that, you know, just that last run, even with that patient, because it's not their fault. That they're your last patient of the day, you just got off 12-hour shift, right? And they can pick up on that, and that leads to lower patient satisfaction, and ultimately worse overall well-being, because it affects them mentally. Because if they say they're in the hospital and they've been there for days, you're the only their care team, the doctors, nurses, techs, they're the only people they see from the outside world. So if you're bringing in that negative energy, that negative emotion, they can pick up on that and they might absorb that negative energy. So some solutions to this are, you know, upon physician well-being, strategies that improve a doctor's emotional wellness will optimize the doctor-patient relationship. For example, mindfulness meditation techniques, work hour restrictions, participation in balance groups, and programs to promote personal health. So this goes along with you can't take care of anybody else if you don't take care of yourself. I mean, it's hard. It's easier said than done, but it's really important to know that your burnout and your well-being does not only affect you, it affects the others around you. And in terms of ill patients, like it's important to have that positive energy when you come in. So do whatever it takes to take care of yourself so you can take care of other people. It just goes along the line with you can't love anybody unless you love yourself. Same thing happens here, same thing translates. So take that extra time to take care of yourself, do what you like to do, take that extra hour, during lunch break, go to the gym, take a walk outside. I know it's hard. We're inside all day, it can get us down, so go outside. It can be little things that make the biggest difference. Okay. Next. All right. So some provider factors is, doctors in training in medical school, or interns or whatever, or early in their career. So some strains that this can have on the relationship that they have with their patients is patients may not trust the doctor's competence due to his or her young appearance or apparent lack of confidence. Um, this has happened to me as a nursing intern. Or during my clinical rounds, I would go in to say, give a medication, and they look at me and they're like, "How old are you? You look like you're in high school. Are you sure? Are you my nurse? Are you sure you're gonna be able to do this? Like, do you need somebody?" And just because I look young. Um, and this can be incredibly frustrating, especially for doctors trying to get that experience. Because, like, if the patient doesn't trust you, how else are you going to get that experience? And you kind of have to prove yourself, which even adds more pressure. And it can be hard to have the same relationship with somebody who simply doesn't trust your abilities. And also, patients might be reluctant to receive ongoing care from an inexperienced physician. Patients may request care from an attending physician rather than from a resident, for example. It's hard because, and it can be very disheartening and impede your confidence because that patient doesn't have confidence in you. Um, and they might request somebody else, and it happens for different reasons why a patient wants another doctor. But you can't let it affect you too much personally, because there'll always be another patient, and um, you're gonna have to get that experience somehow. But so say this, you are as a new doctor, or provider, nurse, or whatever, you have this patient who's a little iffy about your abilities. So some solutions is take the time to explain your clinical reasoning to a patient to demonstrate competence. You know, before, if they're a little hesitant, like, oh, I don't know if I want you to give, like, start my IV. I don't know if I want you to do that. Have you done this before? You know, take a step back, take a pause, and be like, hey, I did my time at this school and this training. I've done this blank many times. Yes, I'm young. Yes, I am new, but I need to get that experience somehow. But I have done it before. And I would like you to trust me because I think I'm confident in my abilities. Um, you know, rep your cred, rep your school, say what, if you're confident in yourself, if they see that you're confident in yourself, they will be confident in you. So take that time to prove yourself, uh, even verbally if you have to. And then another way is get to know your patient. If you get to know them, if you take that time to get to know them, and they can get to know you, they might, if they like you more, they might be more willing to trust you and to let you you know, get that experience with them, or to let you do things with them because they like you as a person, and they're willing to uh, to take a chance on you. So another thing is demonstrate caring for your patient. Skill level might not be the the skill set of a attending, but or that's somebody who's been in the game for 50 years, 30 years, 20 years, whatever. But if you show heart, if you show that you care and that you want to get better and you want to take care of them, you want to do the best you can, it will just increase their confidence in you, you know, because if you show that you care, they're like, okay, they care about me. They're not just going to make a careless mistake, right? Okay, next. Okay, so the next, I think the last provider factor we're going to go over is conflict on or with the treatment team. That that you're not the only person that is in the care team of taking care of this patient. Um, whether it be another like techs, nurses, other attendings, uh, another specialist, whatever. There's conflict. There's somebody who's been doing it for 30 years. You've been doing it for 5. You guys might have different perspectives of what you think or what treatments you would like to try. So even that outside conflict that doesn't really have to do that direct conflict with the patient, can still strain your relationship that you have with that patient. So, how it can strain the relationship with your patient is if a patient is given mixed messages by members of the healthcare team, faith in the team's ability to treat the condition may be lost. If they hear from one person, hey, they're gonna give you this medication for this. And then you come in, you're like, hey, actually, I'm gonna give you this medication. They're like, what is going on? Do y'all know what you're talking about? Like, hold on, wait a second. Like, what's going on? Do you guys even know what's going on? Um, so another thing is if a team members fail to communicate effectively, for example, during a shift report, then the doctor starting a shift may not know the patient enough. So if somebody else is coming off 48-hour shift, 12-hour shift, 24-hour shift, whatever, and they're exhausted and they're just giving you like the highlights, but not really going into detail about this patient, you don't really have the necessary information and skills to be able to actively and efficiently have this relationship with this client because you don't know anything about them. You don't know what's been going on with them. Um, if that person from the previous shift doesn't communicate that with you. Um, so if you go in not knowing that information, that I mean, the patient can tell. It's like, do you know what's going on? Like, are you, you know? And then the next thing is physicians may be distracted by team conflict and be unable to focus on the patient and his or her problem. So you might be so worked up about and frustrated over, this issue or this miscommunication or this different ideas or personalities that you have with your coworkers, that it might transcribe onto how you communicate and how you address that patient because you know, you might bring it into the room with them because you're so frustrated, you're so upset. Um, and that patient, again, will be able to pick up on that and it might impede your relationship. So, some solutions that can help with this is use structured communication formats and regularly scheduled care team meetings to improve teamwork, include teamwork instruction as part of the general medical education. So, make sure that everybody on the team is well informed and on the same page before anybody interacts with that client or the patient or anybody begins, working is like establish that baseline, that ground that everybody, can move forward on the same page to not confuse the client or yourselves and to still so everybody can have that meaningful and effective relationship with that patient because you all are on the same page. Okay, so we've talked about, what's your, as a provider, what things that you could do and you need to do to make the best out of this time and that you have with your patient to in order to gain that rapport and that trust with them. But like I said earlier, this relationship that you have with them goes both ways. It cannot just be, it's not just on you to have that effective communication, that effective relationship with them. So what is the role of the patient for the relationship? So, while it can feel that you as a provider have all the responsibility and pressure to create an effective and meaningful relationship with your patient, it's a two-way street. Patients' experience with their provider depends on how much they participate and how much of an active role they choose to take on in terms of their health. Um, like how involved do they want to be? Are they asking? Do they want to ask those questions? Do they want to know what's going on? Do they want to take an active role in their care? So it's called patient activation. Patient activation occurs when individuals believe that they have an important role in their health and healthcare and have the knowledge, skills, and confidence and emotional commitment to perform that role. Um, does that patient have the have they done their research on their condition? Do they come with questions? Do they want to know how to get better? Do they care about their care and their health? You know, um, because if they don't care, you can't force them to, and you can't really have an effective and therapeutic relationship with them if they don't really care, or if they don't really ask the questions, or they don't really talk to you. Um, so, improving and sustaining higher levels of patient activation is desirable because patients who are more activated are more likely to engage in self management behaviors that can improve health. So, the more active and curious and confident and knowledgeable they are with you and during their time in the care setting, will reflect and roll over into the time that they're not with you and how much they're willing to change your behavior and continue that self-management care at home. So here's a little chart. Um, engagement improves outcomes. Higher patient engagement is associated with numerous improvements across various aspects of health delivery. So you can see on the left here with some percentages statistics. So This is the less activated or less engaged patient, and then the darker blue is the more activated or engaged patient. So, in terms of being readmitted to a hospital within 30 days of discharge, you see that the less engaged patients are 28% likely to be readmitted within 30 days. And then, but the more engaged patient and the more knowledgeable and skilled and active role that a patient takes in their care, they're only 13% more likely to be readmitted into the hospital than 30 days. So, and another thing is experience medical error. So, I mean, this 36% of less engaged patients, less activated patients, were 36% likely to experience a medical error versus 19% with the more engaged patients. I mean, 36% of medical error, that's kind of big. And then suffering a health consequence from poor communication among providers. So 49% of likely less activated, less engaged, or less involved patients, they're 49% likely to suffer a health consequence from that poor communication because they weren't involved or in their care. I mean, 49% is a big, I mean, it's big. And only 13% with a more engaged and patient because they take that step to do have that communication with their provider and to be more knowledgeable, to ask those questions, to make those decisions, so there isn't a miscommunication because they're taking that upon themselves to be involved in their care and because they care, and so care about their health. So that's a big statistic. That's a big percentage. So that's why it's important to make sure. I mean, as patients and as a provider, to get those patients asking questions, to make sure they have all the knowledge they can. Make sure. I mean, so it's not all up to you, of course. You can't force somebody to care. You can't force somebody to want to be healthy. But if they are, then you want to kind of nurture that and expand it. So, these percentages and their health, I mean, it takes a toll, the more engaged and more involved they are, more confident they are about their health and their care plan, then the better health outcomes. So yeah, like I said, so patient engagement lowers diagnostic testing and health expenditures, lowers referrals to other doctors. That's where that loyalty comes in. That's where that you can have that long relationship with your patient because the more engaged you are, the less referrals to other doctors that they might have to have. Um, and so less elective surgeries, more adherence to prescribed medical treatments, more functional status and faster recovery. Patients see more satisfaction when they're more engaged, and the patients are more well informed and engaged. They carry out, when they're more well informed and engaged, they carry out more health related behavior changes. So, the more they know about their condition, the more you involve them in those decisions, like the more likely they will take it seriously, and the more likely they will go home and uh, do what you recommended to, have those better health outcomes. Okay, so now we're going to go over the four models of the physician-patient relationship. So there's four models, four types of of different dynamics that you can have with your patient, and each of them have a different role for the provider and have a different role for the patient, and they kind of differ. So let's talk about them. So what are the four models? What are they? So as healthcare has continued to change and evolve, so has the relationship between healthcare providers and their patients. The importance of the patient's choice or autonomy, same thing, has continued to grow over time, and these physician-patient relationships have shifted in response and formed groups that have each have their own unique definition of autonomy for the patient. Each of these unique models has their own goals and roles for both the physician and the patient. So the first one we're going to talk about is the informative model. So in this model, the patient is in control and places an emphasis on what they want, what the patient wants, and their wishes, and it must be followed by the physician or the provider. So whatever they want goes. So, in terms of what the role is for the provider in this type of relationship, is the physician provides the patient with all the necessary information in their medical, their specific medical situation, and then the patient chooses their desired treatment or what their plan is based off of the physician, what their information, and the physician is required to execute the patient's chosen medical intervention. So here's a real life example of this type of relationship in play. So a patient was just diagnosed with stage 2 ovarian cancer and has a variety of treatment options available to them. The physician, using the informative model, would inform the patient of all the benefits and risks of each treatment option and any other relevant information associated with those treatment options. Then they would allow the patient to consider the information, and then the patient would choose, without the influence of the physician, what treatment option they think the patient thinks is best. The physician would then move forward with that treatment plan and follow the patient's decision. So, some pros and some cons of this type of relationship or this type of model um, is some pros are: the informative model ensures that the patient is completely informed of all their available treatment options and has informed consent when making a decision. And also, the patient's autonomy or patient's choice is respected and is not influenced by any outside opinions from the physician that may lead them to a choice that they actually do not want. Some cons to this type of relationship is the informative model lacks the essentials for an ideal physician patient relationship. So this type of relationship is not ideal. The physician should not just give facts, but also have a sympathetic approach and be allowed to give their recommendation to help the patient make the best choice, because you are the one with the training and the knowledge, not them. The patient may not be completely sure of what they value in their medical scenario, and the experience and knowledge of the physician may be needed to help guide the patient if they are overwhelmed or confused. So, yeah, not ideal, but it is an emphasis on what the patient wants and what their goals are. Okay, so next we're going to talk about the interpretive model. So that was the informative, this is the interpretive. So in the interpretive model, the role of the physician um, is to be for a kind of a counselor or a mentor, and help their patient understand what helps their patients understand what their values or wants are, and help them select the medical interventions that best match those goals. The physician must not simply choose for the patient, but work hand in hand to find the medical intervention that help the patient achieve their desired outcome and goals, to kind of guide them to make those decisions. So here's a real life example, again with the ovarian cancer. Um, a patient may just a patient was just diagnosed with stage 2 ovarian cancer and has a variety of treatments available to them. The physician, using the interpretive model, would discuss with the patient what their future goals are and provide all the necessary information about the treatment options available and how they align with and help the patient reach those goals. The physician would inform the patient on what treatment they think best matches the desired outcome of the patient, and then the patient would come to a decision using all of the provided information. So, some pros and some cons to this model or in this type of relationship are some pros. The interpretive model allows for an active discussion between the physician and patient to determine the best medical intervention. This allows for the physician to share both their expertise and maintain an empathetic approach while working with the patient. The patient may be confused on how each treatment option will fit into their future goals, but can come to an understanding after discussing with their physician. Some cons to this model are: physicians may unwillingly impose their own values or subconsciously impose their own values onto the patient while believing they are following the patient's requests. And also, the physician may be wasting time by focusing on future goals and values that are not extremely relevant to the situation and do not directly apply to this patient's decision. So, You don't want to get caught up in, the future goals and the future aspirations. You want to also bring yourself down to reality of like what's going on right now, what's best for you right now. And that's super important. So next, all right, the third out of 3 out of 4 model we're going to be talking about is the deliberative model. So in the deliberative model, the role of the physician is for the physicians aim to help their patients determine the best health related values that can be applied to the medical scenario and which health values are present in their available treatment options. The physician must identify and establish what health related values are important in their patient situation and what values are beyond the scope of their professional relationship, such as political and social values. So the physician can then provide their recommendation to the patient on what values um, they should pursue and what medical intervention allows them to accomplish these values. So it's more of the physician imposing their own values and what they think is important um, to the patient, and they're going to tell them what they think is most important. So here's a real life example again with the ovarian cancer. A patient was just diagnosed with stage 2 ovarian cancer and has a variety of treatment options available to them. The physician using the deliberative model would determine what health related values, such as survival risk and side effects, are prevalent in the situation and how they play a role in each of the treatment options. The physician would then inform and discuss with the patient what values are most important and allow the patient to then choose the treatment option they believe embodies their health related values. So, some pros to this model is the deliberative model empowers the patient to not only be informed, but to have a self understanding of their situation and treatment options so they can use their autonomy to its full extent. The physician does not only inform the patient, but can actively engage and provide recommendations to use their knowledge in a way that benefits the patient. Some cons to this deliberative model are it is likely that the values a physician considers to be most important will not always be what the patient thinks is most important or other members of the healthcare team think is most important. So, this means a physician's recommendation of like what treatment they should go can vary from physician to physician. So, because the physician is able to use their own personal values in this model and what they think is the most important, it can be different. Not everyone has the same values. Not everyone you know thinks about what is important or what should be priority. So, it can be information can vary in the healthcare team and can be confusing. So, patients may see this method as a waste of time as they do not want to engage in moral deliberations but receive instruction on how to receive the quickest, most efficient treatment. I mean, sometimes the patient was like, okay, I don't care about, your values, what I just want, just do it, right? Just do it. I don't care, just do it. So, sometimes they might not want to get worked all into the hypotheticals and, you know, other situations. So, the last model that we have is the paternalistic model. So, in this model, the role of the physicians, they use their skills to determine the patient's medical condition and identify the medical tests and treatment most likely to restore the patient's health or relieve their pain. This model gives the physician more control over how the medical intervention will play out and consider it acceptable that the physician will most likely have the greater knowledge on how to ensure the patient's health is benefited. So, in this model, paternalistic physician is in control, basically, because they know best, or a physician knows best, right? And everybody just kind of has to accept it. Okay, so some pros to this model are the deliberative. Oop, I think I. Oh, no. So we're going to do some real life example. Sorry, my bad. So paternalistic model, real life example, patient was just diagnosed with stage 2 ovarian cancer and has a variety of treatment options available to them. The physician using the paternalistic model would then review these options and identify what treatment they feel is best suited to help the patient recover. Instead of explaining all possible options, the physician would then tell the patient about the treatment option they feel is best suited to help them. and provide the patient with an explanation and evidence regarding the treatment that supports their choice. So they don't really explain all the available options, they kind of just tell them what they think is best. So, some pros to the paternalistic model is in emergency medical scenarios, it may be necessary for the physician to make the patient's medical decisions for them if it is difficult to obtain informed consent from the patient due to their condition. I mean, this happens a lot in the ER. The patient might come in from the ambulance being unresponsive, and it's up to the ER doctors and the ER team to kind of do what they think or do what they can to get the patient better because the patient is not in a state to give that consent and to be a part of the decision making. So, in many medical scenarios, the physician has both greater knowledge and experience in the patient on what medical interventions would work best in their situation. Giving the physician more control over leading the patient can help prevent the patient from being confused or overwhelmed. Some cons to this, though, in daily physician patient interaction, it would be wrong to assume that both the patient and physician share the same beliefs and values, which the paternalistic model assumes. So, when you give all control to the physician, you're kind of assuming that, that they share the same values and opinions that the patient does, and it's not really realistic. So another con is the physician may be unethically withholding information that would alter the decision making of the patient to help reach the conclusion that the physician considers best. So, like I said earlier, the physician really doesn't tell them all of their available options. They kind of just tell them um, the treatment option that they recommend and why. So they would be kind of withholding that information. It's not ethical because you want to present your patient with all of the options so they can really make a decision, so they can be at least informed of all the available treatments available to them. Okay. So this is kind of just a graph about the rundown of all four models that we just talked about. Um, so yeah, paternalistic model in terms of this is a physician or provider point of view. So paternalistic model, I the physician decide for you. Informative model, I the physician give you the facts for you to make a decision. The deliberative model, and I give you the facts as a physician. I give you, my patient, the facts, but in addition, I also tell you what my preferences are and what I think is best, and I recommend. And then the interpretive model, I give you the facts and help you to find your preferences. So we go over really emphasis on what you value and what your goals are, your health goals. So, ready for a quiz? Da-da-da. Okay. So, this quiz is to test your understanding of the paternalistic, informative, interpretive, and deliberative models, each offering distinct perspectives of the physician-patient relationship. So they don't really have a right or wrong answer. It's more of like your opinion. So challenge yourself with the questions that navigate ethical considerations, communication styles, and the evolving nature of patient-centered care. So you're really deciding what you think. In these questions. So, and you can kind of self reflect on what you think the role of the patient and the physician are in a relationship with each other, or in this patient physician relationship. What do you think? How much autonomy should we give our patients? All right, number one. Okay, so what do you consider the role of a physician to be? A guardian for the patient, someone who keeps their best healthcare interests in mind. B, a counselor or advisor, someone who knows the patient's goals and tries to coach them to find a treatment that aligns with those goals. Or C, a competent technical expert, someone who gives them the information they need and lets them make their own choice. A, B, or C. Number two, what do you believe about a patient's values? A physician can understand and share the same values as their patient. B, if a patient may have pre-established values that can be changed based on the discussion with their physician, or C, a patient's values are well known and already established without the physician. A, B, or C. Number three, what do you believe to be the physician's primary obligation to their patient? A, providing relevant and factual information to the patient and executing their selected medical intervention. B, promoting the patient's well being regardless of their own preferences. C, discussing and persuading the patient what health values are most important with each treatment in their scenario and executing the patient's selected intervention. A, B, or C. So, with that being said, which type of relationship, which model is best to use? We went over all of them. They all have their pros and cons. So, which one do we use? Which one, that's why I had you kind of self reflect on what your personal values are, and and how you kind of see the relationship that you have here with your patient. So, which one should we use? Because they're all four out there and they all four happen. So, in recent decades, there has been a patient centered shift in healthcare and an ongoing debate on what is considered the ideal model for the relationship between providers and their patients. Physician dominant models, like the paternalistic one, have been replaced by models in which more emphasis is placed on respecting patient freedom and shared decision making. However, controversies, still exist about which model is best and how much healthcare providers should involve themselves in the influencing patients' values, goals, and decisions about their health and about their treatment. How about, maybe the choice between a patient dominant and various middle ground models should be made on a case by case basis, depending on the needs and wishes of the particular patient. There may not be just one ideal model of the relationship between providers and all their patients. So it's really a case by case scenario. You kind of have to, uh, that's where getting to know your patient and getting to know them and their history, and it's really important in when decision making time about you know again, like with health literacy, do they have the capacity and the ability to make those decisions? So it really is depending on the patient. Okay, so next we're going to talk about how much of themselves should the physician or provider bring to the relationship. How much should they disclose about themselves? So, patients may feel more connected to a physician when they know something of the physician's life, and it may sometimes be necessary or acceptable to share information about family or personal matters. However, it is important to keep the conversation focused on the patient, and it is imperative that the provider maintain professionalism. You know, Sometimes it's needed to really get to know somebody on a human level. Um, Especially when you're considering other treatment options or whatever, sometimes you need to bring in that personal experience to build that rapport and build that trust and that loyalty with that patient. But it's important to, even if you do share information about yourself, to bring it back around to them and to the patient centered, and maintain those boundaries, maintain that professionalism. So, sometimes it is necessary, like I said, and provider disclosure can serve a few purposes and beneficial purposes for sure. Physicians sharing personal experiences to serve as a model, as a role model, as like, I've been there before. This is what I did. I've done it before. I understand where you're coming from. Sharing in this way shows reciprocity and reveals the physician to be as human as the patient. Sometimes it can help ease their nerves about the situation, help them feel not alone in their decision making and their situation, because you've been there too, you've seen it happen, and you're not this person, this immortal person. Like, you are human just like them, and it could happen to you. um, Also, physicians may also share information about themselves with patients to improve the relationship. By disclosing personal experiences, physicians can show empathy for patients' current experiences and enhance a spirit of mutuality. Also, physicians may talk about their experiences to lend authority to their recommendations. Like when you're hey, this is my recommendation for your treatment. Maybe try to be like, if they're iffy about it, be like, hey, I actually did this for one of my other patients and it worked out really well for her. Um, Here are some tips I can help you with. Like, I've seen it done before, I've dealt with it before, to kind of ease their mind and establish that confidence in you. And so it sometimes, without violating HIPAA, of course, uh, you can maybe talk about your previous experiences that you had with their condition or with their disease or with the treatment that you're recommending to them. Okay, let me take a drink real quick. All right. Okay, doing good on time. Okay, so next we're going to kind you navigate through unique types of relationships that you can have with your patients, or scenarios that might arise that is kind of taboo or something that is just not that doesn't happen to you every day, right? Um, and you want to be prepared for that because you never know what you're going to get. And so here are some few ones that we're going to go over. All right, so the first situation we're going to talk about is romantic or sexual relationships with patients. Romantic or sexual interactions between physicians and patients that occur at the same time as the current patient relationship are unethical. Um, Such interactions detract from the goals of the patient relationship and may exploit the vulnerability of the patient, compromise the physician's ability to make objective judgments about the patient's healthcare, and ultimately be detrimental to the patient's well-being. And we're all human, and obviously, the type of relationships that we have with our significant others are are different, and they just are a different level of intimacy, and it's kind of impossible to have that neutrality as a physician or provider, when you care about them on that deep level like that, that we do a significant other. So it's not ethical, and it can ultimately be detrimental because of those new and heightened emotions that you have towards that patient. So yeah, a physician must terminate the relationship that you have with that patient before beginning a dating, romantic, or sexual relationship with that patient. Um, Also, sexual or romantic relationships between a physician and even a former patient may be influenced by previous physician-patient relationships and can be unethical, because you were that just the relationship you had with that patient was just you were just their doctor, and you had that trust, that loyalty, that regard, that knowledge, but it wasn't the level that you are at now. Um, and sometimes, if they establish feelings during that type of relationship that you had previously when you're just their doctor, it can kind of influence or falsely influence the relationship that you have, moving forward. So it can be unethical, and it can because you know things about them that you shouldn't know when you're starting to date somebody, and it can kind of cloud, those lines can be blurred. So, with that being said, if a physician and healthcare provider believes that a contact or treatment of a patient could even lead to an inappropriate relationship, it should just be avoided altogether. We're human, you know. We get the vibes. We can, if a patient's flirting with you and you're open to it, it's just easier just to assign a different physician to them, or take yourself off, remove yourself completely, so you can have a normal relationship with them on an intimate level instead of being their doctor or their healthcare provider. So the next situation or type of patient relationship we're going to talk about is having that patient-provider relationship with vulnerable patients. Vulnerable patients, or the vulnerable population, include patients who are of racial or ethnic minorities, children, elderly, socioeconomically disadvantaged, or underinsured. So we're all going to come across somebody in this vulnerable population, a patient, and yes, you want to treat them like everybody else. You don't want to treat them any differently, but there are some certain accommodations and some certain, things that you have to be sensitivities that you have to be aware of. So the patient provider relationship is one factor that can improve access to care for vulnerable populations. That relationship with them, they might have never had that before because they've never had access to somebody like you who's willing to take a chance on them and willing to have that relationship with them and care about them like that. Vulnerable patients often experience challenges in having a good relationship with providers. Um, it comes with biases that in the racial and economic or racial and minorities, the ethic, uh, yeah. And, they might have had bad experiences in the past with providers. They might not trust, like sometimes, um, racial minorities, sometimes they don't trust. They have this distrust in the healthcare system, and so they've never had a really good relationship with their doctor before. So it's important to be aware of that. So factors that could affect the patient-provider relationship with vulnerable patients is health literacy. We talked about that earlier. Their capacity and their educational background, seeing the same provider continuously, and self-rated health. So health literacy is the ability to obtain, read, understand, and use healthcare information in order to make appropriate health decisions and follow instructions. Vulnerable patients tend to report low health literacy, and there's a link between health literacy and the patient-provider relationship, and it can be a significant factor that affects the quality of care. If they don't really have the capacity to know what you're talking about, or be able to take care of themselves, or do what the instructions or recommendations that you're giving them. So, continuative care refers to seeing the same provider continuously on a regular basis. Continuum of care can be a significant factor in the patient provider relationship. Higher levels of continuity of care are related to better instructions from providers among uninsured primary care patients. So, that goes along with access. They might have never had that access to a provider on a regular basis before. So, it you can use this opportunity for people who maybe never had access like that to really strengthen that bond with them, because you could change their life, you could change their health for the better, and it could be really rewarding for both you and them. Self-rated health is a single item that captures how healthy people think they are. It asks, and basically in general, would you say your health is poor, fair, good, very good, or excellent? Vulnerable patients are more likely to report lower levels of self-rated health than patients who are not vulnerable. How vulnerable patients perceive their own health can be an important determinant on the quality of the patient-provider relationship. If they don't think they're healthy, if they don't really care about their health, or they're not very confident in their ability to be healthy, it can impact your relationship for sure and your dynamic with them. So next, we're going to talk about, this is kind of a very unique one that you might not see very often, but it's the physician inmate, physician prisoner relationship. Yes, and in incarceration, prisoners and inmates have, you know, medical staff if needed, but sometimes it requires more than that, and they might end up in your hospital and then in your ER. It's a very real possibility. It happens. So you want to be prepared for what to do, right? And how to, navigate that dynamic. It's very different than a normal patient that comes in to see you. So the physician prisoner relationship is different from the traditional physician relationship. The physician's first duty is the health and the safety of their environment and the people in the community rather than to the patient. However, for some inmates, prison is the only opportunity they've had to gain access to healthcare. Prison gives them the chance to be taken care of by a physician, which is a luxury for many. For some, they may have been in the care of a trained physician. They have never, maybe for some, they've never been to see a trained physician until they were placed in the correctional system. So going back to it's the physician's first duty to, keep themselves safe and the others around them, rather than to that inmate, the patient, because they've been they're incarcerated for a reason. You probably won't know the reason. So it's better to err on the side of caution, um, and to take those necessary steps to, protect yourself and protect others around you, and before, you know, seeing that patient or caring for that patient, because, they're in there for a reason, and they can be unpredictable sometimes. You want to keep yourself safe when having even the strained relationship with them. But and on the other side, inmates a lot of times come from those vulnerable populations, and they may have never had that access to healthcare before, or quality healthcare before. So, being in this prison system and ending up on as your patient, it might be the first for them. So, you could change your life ultimately, change their view on healthcare, and give them something that they never had before. So it's an opportunity for you to establish that dynamic, and with them, and really hear about where they're coming from, and have that empathy, being open minded. All right. So next situation we're going to talk about is when patients, when your patients and speak a different language than you, when they don't speak English at all, when they, their native language, their fluent language is something different than yours. So communicating across language barriers is a challenge for clinicians and health systems. In the United States, approximately 20% of the adult population speaks a language other than English at home. Of this group, of the 20%, almost half reported speaking English less than very well and are considered to have limited English proficiency. I mean, 20% of the adult population speak a different language other than English. So it's a real, real, real possibility that you will encounter a patient that comes to you and does not speak English at all, or speaks very, very limited English. And, you know, communication is a big part of having a relationship with that patient. So it's important um, that you're able to be prepared to have just as meaningful relationship with them as you do your English speaking patients. And honestly, it really takes even more work, but it's more important to them too as well. So communication between the healthcare provider is the key to a successful patient-provider relationship. However, just because there's a language barrier does not mean you cannot still have a meaningful relationship with your patient. Um, just you know, obviously communication, and they need to hear what you're saying, and you need to understand them and what's going on with them. But there's other ways to still have that, relationship with them. So, tips for communicating with patients who do not speak your language. So, first, you want to identify the language that they speak and the language gap, and build that trust. So, some people might not want to speak because they fear, not being able to get their point across. They might already have that anxiety, already have that, they know they don't speak English, and they know that, you most likely do. So it can be really heightened their anxiety, heighten they might not be super comfortable already, even more than the average patient. So the patient already feels vulnerable because of a medical concern or whatever reason they're there, and the communication barrier can make things worse. Once a language barrier is identified, it becomes a matter of building trust so that effective communications can still happen. So, you need to identify it, that language barrier and that language gap, as soon as possible, so you can move forward. So figure out what language they are speaking and what's their proficiency level, and if they speak English at all, and if not, you know how to move forward. So one thing that you can use, I mean, we all have it on our phone, is Google Translate. Um, so once you assess the situation and put your patient at ease, that you're gonna, like, you understand what's going on right now, you consider using Google Translate or another language translation app on your smartphone. Is a simple way to get the conversation going. We all have our phones on us all the time, so you put it to use, and really, really take advantage of that. I mean, just because they don't speak your language doesn't mean you guys can't communicate. So although the translation might not be perfect within grammar or whatever, you can usually get the message across. And it also shows that you're willing to try and that you care enough to hear them and even though they don't speak your language, you want to get to know them, you want to hear them and what's going on, and you're trying, and that goes a long way. Second thing is to use a professional interpreter to convey medical information. Um, Usually, every hospital has either a professional translator on site or through technology. Even though it's not available everywhere, but if you have it, utilize it. So even though you can do a lot with translation aids such as Google Translate, an approved medical interpreter is a must when you have to relay medical information such as anything regarding their diagnosis, orders, surgery, their medicine, prescription, or any paperwork, especially requiring informed consent. Um, Even a fellow coworker who speaks that language and you call them in to explain that technically is not the right way to relay information, that needs documentation. So, all the important stuff, the stuff that they have to understand for you to be able to do your job legally, especially, you want to make sure you hit all those boxes so you don't have a legal problem on your hands. And so you want to use that professional translation service um, to convey that important information, especially when they're signing something. They need to have that informed consent in their native language. And then also something you can do is just learn key phrases. It obviously depends on what location you work at, what type of environment you work at, what's the demographic in your environment. But, say you live in Texas or California and with a high Hispanic or Latino population, like so learn for common medical phrases that you would use in Spanish and have them already in your mind to kind of have that first, so before you have to bring out Google Translate to kind of assess the situation. So, if it helps, you can learn key phrases that are simple and you use often, such as like, do you have any pain? Eat, drink, where is your pain? Sit down, turn over. Just like the most basic things that you have when you encounter a patient, um, so, just to kind of get the situation started, get the conversation started, and before you have to bring out Google Translate. It's just easier, it's faster, more efficient. So this can help put the patient at ease and address the situation before a translation service is available. And mind nonverbal cues and be compassionate. Ultimately, nonverbal cues are just as important as verbal cues for effective communication and building a relationship with your patient. Nonverbal communication, such as body language, um, is even more important in patients who do not speak the same language as you. If you're giving positive nonverbal cues, then it definitely makes them feel as if you're at least a friend. Uh, yeah, just like mime things out, that nonverbal communication. It's a universal language we all speak. Like everyone knows this, like everyone knows this. So it's like use those to your advantage. I mean, it might seem silly, but uh it can help like still have that rapport with them because not that intimacy is not just communication. It's not just the words we speak. It's how we feel, and you can you can get that communication just by even not talking at all. So act out requests. For example, if you want them to take the medication and drink, sometimes it helps to physically show them, and they know what you're talking about. Like you know, nonverbal cues goes a long way, especially when you can't always just sit there and just type out Google Translate all the time. It's not very effective time wise. And then also consider the role cultural differences play. You know, figure out their culture, figure out their background, figure out their language they speak, and all, as much as you can, so you can, move forward and be respectful of their culture because cultural differences do affect the way we communicate. For example, many cultures and even older generations may get offended if healthcare workers address them by their first name. So err on the side of caution, especially when you're dealing with a new language or new ethnicity or new culture that you're not super familiar with. Also some cultures tend to bring many additional family members to appointments or to the emergency room. So, educate yourself if you can, and be respectful. Remain flexible and respectful of these cultural differences. It might be uncomfortable at first for both of you, but It's a barrier you have to get with, but they're still your patients, and you still have a duty to them. Okay, so the the next situation that we're going to talk about is gifts from patients. Um, patients offer gifts to a physician for many reasons. Some gifts are offered as an expression of gratitude, or even a reflection of a patient's cultural tradition. As I said, educate yourself, be respectful. Yeah, be adaptable. Accepting gifts offered for these reasons can enhance the relationship. It's the gratitude. It strengthens relationship, and especially if their cultural background, they give you a gift that means a lot to them. If you accept it and you're open minded and with gratitude, it can strengthen that relationship you have with that patient. Um, However, some patients may offer gifts or cash to secure or influence care to secure preferential treatment. Such gifts can undermine physicians' obligation to provide services fairly to all patients. Accepting them is likely to damage the patient's relationship. So, gifts can be good and bad, and it's important to know the difference. So, physicians who are offered a gift from a patient should be sensitive to the gift's value relative to the patient's intentions. Physicians should decline gifts that are disproportionately or inappropriately large, or when the physician would be uncomfortable to have other people know that they accepted that gift. If other people are like, "Oh, that's not right," just don't do it. Not allow the gift or offer a gift to influence the patient's medical care. Make sure they know that too. Make sure you communicate that, even if you do accept the gift, that this is not this is not going to impact your care in any way. It's not going to better your care. And then decline a request from a patient if the physician has a reason to believe accepting the gift would present an emotional or financial hardship on the patient's family. Make sure know it's if it's if it's too big, and you have that gut feeling, and just don't accept it. Like, if you know that they maybe not have insurance, but they're giving you this really expensive gift, you're just like, you know, don't accept it, because it you know their background, and you're there for the patient, and it's not about you. And physicians may wish to suggest that the patient or family make a charitable contribution instead of the gift, just to err on the side of caution and just be safe. Hey, yeah, I don't need that money, but maybe give the money back to the hospital, to help other people like you. The interaction of these factors is complex, and physicians should consider them sensitively before accepting or declining a gift. So now we're going to come back to what we talked about a little bit earlier, is the difficult patient. The difficult patient is someone who struggles to comply with treatment, who might refuse treatment, or otherwise creates friction within the system. We all know them, we all have them, you know. However, the patient identified as difficult by a physician or somebody else in the care team, they're still human, and they're still a patient who is striving to optimize their quality of life. They all have the common goal of wanting to get better, and that's your job. So most people, including healthcare workers, can become difficult. So anybody can, they're human. You can become difficult under certain circumstances, and you'd want that respect, if you were in their situation. So it is the responsibility of the practitioners to contemplate what could facilitate and reinforce the physician patient dynamics in which they are involved, and avoid actions that jeopardize it. Once the difficult patient label is there, it's not too late to unlabel the patient. Recent publications and scientific research suggest several helpful conflict management strategies to remove the difficult patient tag. So there's certain things that you can do to enhance that relationship and make the best out of it, which leads us to managing conflicts with patients. So it's not uncommon for providers to become involved in conflicts with patients, especially dealing with that high stress environment and high stress situations that you encounter, especially when they're being vulnerable, emotions running high. You know, they can act out, they can lash out. So why does a patient provider conflict? Sometimes, why does it occur? What happens? Uh, what causes it? For example, the healthcare provider's actions, those may be the problem. um, for example, the provider may be rude or dismissive to the patient, or late for an appointment, and so on. So, it as much as we would like to blame it on other people, it can be our fault. um, or a patient may feel offended by a patient or provider's tone and attitude. Um, and then another reason may be a patient may become frustrated with their provider due to factors such as stress of their health concern. They might take it out on you with anger or aggression. Um, Given that healthcare providers are trained in effective patient communication, dissatisfaction from the patient's perspective is a primary cause of conflict. So that's the primary cause of conflict is, you know, whatever the patient's dealing with internally and emotionally, and they lash out at you. Um, and then sometimes it can be external factors such as short appointment times, delayed waiting times, or a lack of effective resources. Also, can create stress that may, you know, hinder, like, it may cause conflict. So, some strategies for resolution. So, the most basic things that you can do is, understand the patient's anger, where they're coming from. Why they're upset is really the main part of it. And then, understand your own emotions and try not to, you know, counter transfer those emotions, uh, so you can prevent a conflict from worsening. You don't want to meet their emotion with emotion because it'll just, you know, make the situation worse. And then you want to maintain neutrality and showing benevolence, identifying the naming the problem, apologizing, and then educating the patient. So understanding the patient's anger or the patient's emotion. Um, Anger is an emotional reaction. Uncovering its source is helpful for the relationship. If you want to continue to have a relationship with them, you have to manage their conflict. And you have to deal with their emotions, just like you deal with any other type of relationship you have in your life. Often, the patient really only wants to be heard and acknowledged by the person that is supposed to be caring for them. I mean, they just want to be heard, really, for the most part. So if you acknowledge the emotions, I mean, if the provider patiently lets the patient verbalize their anger or their emotions and gently and empathetically tries to find the root cause of frustration, it often gets better. So a little mnemonic that you can use is nurse. Name the patient's emotion, understand and legitimize the feeling. Be like, okay, I understand you're angry, and I understand why, because you feel like this. Tell their emotions back to them, make them feel acknowledged. You want to respect and where they're coming from, even if you don't agree. You want to support them, like you want to be like, yeah, I understand, I want to help you, whatever. And then explore by asking the patient to elaborate on the emotion. You know, okay, so why do you feel like this? What would make it feel better? What would you like to do? Problem solving, while still acknowledging their emotions. They don't want to be dismissed. Yeah, understanding your own emotions and counter transfer to prevent a conflict from worsening. When patients feel ignored or not listened to, when they feel that their needs are not considered, or even they are being blamed, their anger only increases. During this situation, it's likely for the healthcare provider to become defensive. Um, you know, we're human too. We're not robots. We have emotions, and sometimes you might react and become defensive like you would. You're human, right? But the undoubtedly tricky task falls on you as the physician. Resisting the urge to blame or react impulsively is critical to avoid an unnecessary counterproductive situation. Maintaining neutrality and showing benevolence. The maintaining of neutrality and calm increases the chances of resolving a conflict. It improves our capacity to listen and to pay attention. The provider must set aside their own interests and ego whenever there is a problematic interaction with the patient. Identifying and naming the problem. Identify and try to give a name to the patient's problem proves that you're concerned for them and want to be on the same team with them rather than becoming competitors. Recognizing and naming the patient's frustrations can show that we are making an effort to work with the patient, not against them. And then apologizing. An apology is a universal healing force for resolving interpersonal or intergroup conflict in which one party admits responsibility for an offense. The ability of the provider to apologize is proof of their honesty and understanding of the patient's frustration and can reestablish a feeling of trust. Educating the patient. When it comes to procedures, realities of the healthcare industry and specific responsibilities to the patient, and their understanding is crucial to minimize possible areas of conflict with the provider. This goes back to health literacy. Make sure they understand and where you're coming from, what the situation, like what the reality of the situation is. So, good communication is key to managing these encounters in a way that does not escalate into bad feelings, anger, and poor patient outcomes. Physicians need to be aware of the differing power roles in the relationship and conflicts that arise with their patients. Patients are often fearful in some of the most stressful events that they'll ever have to go through. So, you as the provider, you kind of have to bring that calmness and that neutrality into it to bring down the emotions. Sometimes these conflicts don't resolve. And sometimes, just like a normal relationship, it's not a good fit. You're not always compatible, no matter how hard you try. So sometimes you will have to terminate that relationship with that patient. And it's really uncomfortable. And there's a lot of things that you have to consider. It's a really sensitive subject. So it's good to be prepared on how to go about that. So, terminating a patient physician relationship. Ending a relationship with a patient is often a difficult decision and can lead to difficult and uncomfortable conversations. Physicians may decide to dismiss a patient for a variety of reasons, such as, they don't pay, they don't want to, they don't want to agree to what you recommend, or just basically just inappropriate behavior, right? Whatever the reason, a patient dismissal is a subject of concern for everyone and should be handled very, very, very carefully. Risks to consider before dismissing a patient. So, patient abandonment risks. So, you don't want to just, that can lead to a lawsuit. You don't want to just up and, terminate you know, terminate seeing them in the middle of their care and leave them basically with nothing. So, you want to give it adequate notice, at least 30 days and then, provide emergency medical care for, for a period, and then assist with the continuum of care. Refer them to other physicians that may be a better fit, refer them elsewhere so you don't just kind of leave them high and dry. Um, you want to notify them with a written termination letter for documentation purposes. All decisions to terminate the relationship with a patient should be documented in writing, specifically or preferably a U.S. certified letter, and so the patient understands the need to find another physician. Let them know. Give them a heads up. Give them a written, documented, certified, documented heads up so you can avoid lawsuits and potential damages. So you really want to get the point across without being harsh, and you still show care for them and honestly protect yourself. Time for a quiz. Number one, when dismissing a patient, uh, I must provide a copy of a patient's medical records to another provider, even if the patient hasn't paid for medical care they previously received. True or false? True. You, even though, you know, they're seeing another physician, it's still your obligation, responsibility to give those records over to them so they can still get the care that they need. Number two, I need to send written notice to a patient when terminating a relationship. True or false? True. You do. That written is very, 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 very important. Number three, patient abandonment is an important risk to be aware of when terminating a physician patient relationship. True. It can open up a wide floodgate of lawsuits if you don't do your part, um, in so that you don't just leave them, terminate them in the middle of their care plan, and now they're left with no resources to continue that care elsewhere. Okay, so finally, this is our last part. We're going to go over systemic factors or day-to-day factors, factors we can't control, whatever, that affect the doctor, patient, or physician, patient, provider, patient relationship. And then I'm also going to, give you suggested solutions to impair it, to repair that relationship or to improve that relationship, no matter these external factors. So the first up is time constraint. Time constraint, as us as healthcare professionals, we don't have really a lot of time. We have a lot to do, big job, and we don't always have a lot of time to have that relationship and those, you know, time, just yeah, time constraint. We all have it, busy lives. So how constrained the relationship that you have with your patients though is, doctors may not have or make the time to explain their reasoning to get the patient's trust. You might just kind of tell them what you need to tell them and dip. So you really got to take that time, you know, to explain yourself and to establish that trust and that the patient has in you. There's less time for the physician and the patient to get to know each other. I mean, simply, if you don't spend a lot of time with them, you can't get to know them, and that hinders the relationship. Regard, there's less time to establish rapport. Same thing. You can't establish that relationship with somebody if you don't spend time with them. And then loyalty. Patients are less likely to be loyal to a doctor if they have not developed positive regard. So they might not be your patient for that long if you don't really spend a lot of time with them or spend a lot of time trying to get to know them. So some solutions though, to even during a time constraint, how can you still have that relationship with your patients? Develop strategies to increase workplace efficiency, leaving time for physicians to explain their reasoning, get to know patients, and to establish rapport. By using pre screening forms and questionnaires while the patient is still in the waiting room, or by using simple technologies such as walkie talkies to communicate with medical assistants and other support staff, more time can be devoted to patient care. So, really delegate those other tasks um, to save that time so you can spend that time with that patient. So, delegate tasks if you need to. They're there for a reason. And, here's some statistics on time spent with patients. So, the majority of physicians, 56%, spent between 30 hours to 45 hours of their week with patients. So, majority of their work week, are spent with patients, but not every patient gets that same devoted time. And 5% of providers spent less than 9 minutes per patient, 22% spent between 9 minutes and 12 minutes per patient, 29% spent between 13 and 16 minutes per patient, 33% spent between 17 and 24 minutes per patient, and then only 11% spent between 25 minutes or more per patient. And when you really think about getting to know somebody, that's not really that much time. So another, external factor that can impede the relationship with your patients is not having enough space or, room. The environment, can impact the dynamic you have with your patient and the overall vibe. How it can strain the relationship is if the space is not private, physicians may be reluctant to ask certain questions, which limit their ability to really get to know the patient. Additionally, patients may be reluctant to confide in doctors if they do not feel the conversation is private. They can't really get to know somebody, especially the type of questions that people might not want to share about it to anybody else, and they want to keep private. And that's the important part of the relationship that you have with them, is to establish that trust and the vulnerability. And so if it's not private and other people can, are able to hear, they they might withhold information that could help you in their care for them. So and then also, busy and uncomfortable clinics may make it harder for the doctor and patient to connect. If a lot is going around, a lot of stimulation, they might be distracted, you might be distracted, and it really takes away from that connection. So, some solutions is, whenever possible, take the patient to a private room to ask questions. Take them to another space if they have to, uh, and explain, like, hey, I really want to go to a more quieter place to really get to know you and your situation. It goes a long way. So another factor is a high patient provider ratio. So, you know, patients may feel like they are objects being discussed rather than equals participating in their own care. They may not feel as though they know all of the team members and what their roles are. There may be too many people with whom to establish rapport. This is a special. This is especially prevalent in hospitals. If a patient is there for say 3 or 4 days, they're gonna see a wide range of CNAs, techs, nurses, different providers, different doctors, surgeons, whatever, and it can be very overwhelming for them, and it can be very they might, especially if the doctors and the healthcare team are talking about them in earshot, it can kind of form that disconnect that they might have with that patient and the patient might have with their care team. It can be a very overwhelming and kind of isolate them a little bit. So, some solutions to get over this barrier is, explain each team member's role and how they contribute to the patient's care. Whenever possible, limit the number of physicians who round on a patient at one time. In teaching hospitals where this is not always possible, and during clinicals and for nursing students, team members should introduce themselves to the patient outside of rounds to establish rapport and get to know the patient. If you enter the room, announce yourself. Get to know them. Get have them get to know you is really really important for that to establish that trust. Yes, you assign them, but that doesn't necessarily mean that they trust you or that they want you to care for them. So it's really important to introduce yourself. I mean, we get so caught up in the other things that we forget the most basic levels, basic things like, "Hey, how are you? Hi, my name is," we just get there and we're here to do a job. We're so focused, but you really got to take that time to have the patient get to know you. It can go a long way in their results and their health outcomes and their care and the quality of care for sure. So another thing, what we that healthcare providers, it's 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 prevalent and people physicians hate it, is the documentation burden. And how it can strain the relationship is physicians may spend more of the visit making sure all the necessary, like boxes are checked and, the necessary documentation that they have to have. And, they might be so focused on getting all that information into the patient's chart rather than getting to know the patient as a person. Um, and, uh, and having a computer between the patient and the doctor also makes it hard for the patient to feel like he or she knows the doctor. If you're like staring at a computer screen typing, it doesn't really show that you're listening, right? Um, Physicians may spend much of the visit facing the computer screen rather than the patient, which may make the patient feel as though the doctor does not care about him or her as a person or what they have to say. The amount of paperwork and documentation that is often required also enhances physician burnout, making it harder for the physician to demonstrate empathy and caring. It really impedes your ability to be present in the conversation that you're having because you're so focused on getting the necessary information. And so here's a little statistic about documentation. Is statistics on hours providers spent on paperwork and administration throughout the week. 11% spent less than 5 hours, 18% spent between 5 hours and 9 hours, 38% spent between 10 hours and 19 hours, and then 32% of physicians spent between 20 or more hours just on documentation and administration work alone. On top of already seeing those clients or those patients a week, I mean, it's a lot, and it all contributes to the burnout and the dissatisfaction in the job, and then also, can impede your ability to have a meaningful relationship with your patients because of all the extra stuff. So, some solutions to helping so you can have a relationship while getting your work done is, time saving strategies that can be employed to reduce the amount of time spent on documentation and increase the time available for physicians to spend with patients. When appropriate, write a note collaboratively with the patient during the visit. Like let them know what you're doing. Let them know what you're writing down. Don't just write down things because that's like, what are you doing? If using this approach, either turn the screen so that the patient can see it as well, or arrange seats so that the physician can maintain eye contact with the patient while typing. And it really takes that time management skills, the uh, being able to do multiple things at once, multitasking. But it's important. Like, the body language is everything, and it's as little as making eye contact. So, you know, keep them informed. Let them know what you're doing, because to them, you could be doing another patient's chart, or you could be doing other work while talking to them, and it doesn't really show that you're listening. So, keeping them informed about, hey, I'm writing your chart, like, about stuff. So, like, this is what I'm doing. So I am listening to you because I'm writing it down. Like, it goes a long way, and it shows that you do care about what they're saying to you, and you do care about them. So now we're at the conclusion. Finally wrapping up. So, out of everything we talked about, all these strategies to improve the relationship. So, like, what can you get out of it? What is the result of having a good relationship with your patients? By having a strong relationship with your patients, provide you as providers can see greater patient engagement. And then we talked about earlier how patient engagement can positively impact their care and their health outcomes, and the health system overall. So, if you have that strong relationship, it starts there. Then the greater patient engagement, then the better health outcomes, and then better, yeah, just keep going. So you want to start that baseline to get the ball rolling. Also, it show, like, having that strong relationship, provide you can see enhanced compliance in their treatment program or their treatment plan, even when they're home by themselves, because they have that strong relationship with you. They trust you. They know you as a person. You're a part of their life, and so they want to please you. They want to do what you say because they trust you and they trust your knowledge, and your competency. And if they have that greater patient engagement, like, they care about themselves because you care about them, right? You can also see better patient satisfaction. It goes into quality of care. It can go into your reviews. It can go into just how they see themselves and how they care about themselves, and how they view the healthcare system and their own health. And you can also see better patient health outcomes ultimately. Um, those relationships that we have in our life directly affect our well-being mentally and physically. So whether you might see it or not, you are in their life. That is a relationship that you have in your life, and that is the relationship that they have in their life. And it's like, our relationships in life are important to us, and important to our spirit and our soul. So thank you. Thank you guys for listening. Thank you for taking the time out of your day to come hear me speak about it. And I hope you learned a few things, and hope you really put that into perspective when going on and taking care of your clients, about you just reassessing where you're at emotionally, reassessing where they're at, really taking that time to get to know them. It means the world to them. It can mean the world. It can go so far. So here's my contact info if you want to reach out to me if you have any questions. And then here are the references, and thank you very much. So I'm going to stop sharing my screen and stop the recording, and have a great day.